February is Heart Month, and a healthy heart is the key to a healthy life. Often, people wait until there's an issue with their heart to make changes to their lifestyle. Today, we're talking about preventative cardiology and the simple steps you can take right now while you're watching this show to reduce the risk of a heart attack, stroke, and other cardiovascular diseases. You're watching Stronger Together with Dr. Dave. Hello and welcome to Catholic Health, Stronger Together with Dr. Dave. Today we're talking about preventative cardiology and how our team of St. Francis Heart Center cardiologists can help you understand and lower your risk of heart disease. Joining me now is Catholic Health's Director of Preventative Cardiology, Dr. Tom Pappas. Dr. Pappas, welcome to the show.
Thank you.
So we're going to talk about something that is near and dear to my heart, and I know it is yours, preventative cardiology, and specifically the preventative cardiology program at Catholic Health. Right. So you're the Director of Preventative Cardiology. Can you just give us a brief overview of the program?
Yeah, I think I will. I think preventative cardiology is a good program, but people have other screening processes for other things. For example, if you have breast cancer, you do a mammogram every year. If you're looking for colon cancer, colonoscopy every 5 to 10 years. If you have prostate, you do PSA every year, and that's a good screening for three diagnoses. But the number one cause of mortality across Long Island is heart disease. So preventive cardiology is a program that we're starting at St. Francis and throughout Catholic Health. And I think it's going to explode over the next couple of years to really be a famous program. So what we look for is basically, if someone comes in at age 40 and has no prior history of anything, we'll sit down, talk to the guy. I'll ask him about his family history, ask him about whether he has high cholesterol levels, Lp(a), whether he has diabetes, whether he has high blood pressure. Pressures could be 130/80 and above. Whether he's a cigarette smoker. Those things that I really ask people, one-on-one. And then after that, I can do other studies. For example, we can do a calcium score. We can look for LDL and Lp(a) and ApoB and high sensitivity CRP. We can check the blood pressure and do a lot of things that really would wind up with risk factors. So I think it's a really, really good program. We're going to explode across Long Island, and I think it's going to be a really good program to do. Yeah.
So this program, what I like about the program is typically if somebody watching this show goes to their doctor, typically we talk about risk factors like you just spoke about.
Right.
And that's fine on a population level, but when it comes to individual, there are people who don't have many risk factors and some that no known risk factors who still have a lot of heart disease that they don't even know about. What is a coronary calcium score for viewers to understand?
I think whenever you have even a little bit of plaque in the coronary arteries, calcium loves to stick there. It's like a really phenomenal study to pick up even early progression of plaque in the coronaries. So I think it's a great test to do. Even people in their 30s and 40s, if you get a calcium score, then we put them on lipid lowering therapy, and we do all kinds of things that will keep them going. I think that if they're 80 years old and the calcium score is 0, then I said, okay, it's okay, but don't worry about it. But I think that the calcium score is great. I think the LDL level with the Lp(a), which is a phenomenal test to really be a good screening study for people that may need to be on cholesterol medications. I think those are two really good tests to do. So I think it's a great program.
Right. So just since you brought up Lp(a), most people watching the show will not know what Lp(a) is because a lot of doctors don't even know what an Lp(a) is.
Correct.
Lp(a) is basically a very sticky, bad cholesterol. About 1 in 5 people in the world will have it.
Yep.
And if it's high, quote unquote high, we don't necessarily have a treatment for it, but it's a red flag, right? It tells us we really have to watch this person. So do you order Lp(a)s on all your patients?
Everyone.
Me too.
Everyone.
I do also. And I will bet you most people watching this show right now don't know what an Lp(a) is and they haven't had one ordered. So if you are watching this show right now, ask your doctor if you ever had an Lp(a), and if you haven't, get one.
Yeah.
right?
I totally agree. Totally agree. Yeah.
So you mentioned before an age. When would you start? Somebody who's watching this show, when should they reach out to us and say, hey, I saw the show, I want to get screened. Who is the ideal candidate to start screening?
I would say that at age 40, people come in at age 40 to go full screening. I mean, women are, go through, they reach after age 40, they're through menopause. But after that, they can come in to see me. At age 40, men can come in to see me. I think it's a great cutoff. However, if there's a family history of heart disease, even before age 40, like if you're 30 years old, I would come in to see me. Yeah. And we can go over the whole screening process, and then we can come up with a game plan on that. So I think age 40 is not a bad idea, and I think people should come in and just come in and say, Doc, I got to come in. I'm not getting a colonoscopy, I'm not getting a mammogram, I'm not getting, PSA, but I got to come in to see you guys at age 40. It's not a bad idea.
Yeah, I think it's a great idea. Yeah. And we're gonna end on that note, but I want to just say to people watching this program, you have to advocate for yourself. Do not wait for the healthcare system to say that you should get screened, because doctors are busy, the system's overwhelmed, so everybody has to advocate for themselves. If you have not been screened for heart disease, at least ask your doctor or call the center and find out. You can call any St. Francis cardiologist on Long Island.
Right.
You're out east and you're in Roslyn. I'm in Smith. We have the whole island covered. You can call any St. Francis cardiologist and ask, can I come in to talk about screening? And we'll tell you if you should be screened or not.
Yep, I agree. I 100% agree. And honestly, if someone comes to me at age 35, 40, and they say, yeah, Doc, I don't have any screening process, I'm athletic, all this, but their father died at age 35 from heart disease. I said, dude, you got to come in to see me, and I got to do a lot of screening process. I think it's a very important thing to come and see me.
Yeah, you know what's so funny you said that, because I was reading, don't ask me why, but I was reading the colonoscopy guidelines recently for another patient. Right. And the recommendation with family history is the age of your family member, you start screening 10 years before. Why are we not doing that with heart? The heart disease is #1 killer, but it gives you a lot of time to figure out that it's there. Totally. And that's a tragedy.
Totally. Yep.
So again, if somebody is watching this show, call St. Francis cardiologist. They're all over Long Island. They don't have to be in Roslyn. They could be in many different places. True. And please get screened. Yep. Okay.
I agree 100%. Yep.
We're going to have you back again, and we'll have to get this message out again, because we're going to just have to keep going until heart disease is no longer #1 killer.
I gotcha.
Thank you, Dr. Pappas.
Thank you.
Coming up next, we will learn more about preventive cardiology and some simple steps you can take to improve your heart health. You're watching Stronger Together with Dr. Dave.
As farmers and ranchers, stewardship of the land comes naturally. You help keep water clean, improve the soil, and provide habitat for wildlife. But did you know that conservation can also improve your bottom line? Learn more at conservationpays.org.
Welcome back to Catholic Health, Stronger Together with Dr. Dave. Today we're talking about preventive cardiology, and my next guest is the Director of Intravascular Imaging at St. Francis Hospital and Heart Center, Dr. Evan Shlofmitz. Dr. Shlofmitz, welcome to the show.
Thanks so much for having me.
So we've had you on the show before, and by popular demand, we were asked to have you back on. So we're going to talk about something that is something we don't usually talk to interventional cardiologists about, and that is preventative cardiology. But you have a very unique perspective of heart disease, because you're actually inside the arteries looking at the disease that causes all these other problems, such as heart attacks, bypass surgery, and stents. So let's go way back to the beginning. What are some of the ways that we can start to tell people who are watching the show today, very simple ways that they can start to implement today in order to prevent heart disease later on in life?
Yeah, so absolutely. It's being inside someone's arteries. It gives you a different perspective on the impact of atherosclerosis and how important it is to prevent that. And the earlier you start, the better. And it just starts with an active lifestyle. Exercise, you just have to move and watch what you're eating, eat a healthy lifestyle, and make sure that you're monitoring your risk factors. Annual physical with a primary care, making sure you're checking your cholesterol, your hemoglobin A1C, that your sugar level is optimized, and this way you're getting ahead of the curve before we get to the point where you're developing advanced atherosclerosis.
Right. I think one part of the problem is I think we've made being heart healthy very complicated. With the supplement industry and the device industry. And at the end of the day, unfortunately, I always tell my patients it's hard work, and being consistent, it's exercise. proper diet and sleep also, and obviously the best you can, stress reduction. Are there any tips? I'll tell you what my tip I give my patients is when we talk about nutrition, I always tell them to eat, I'm borrowing it from Michael Pollan, the author, but I always tell them to eat whole food, not too much, and mostly plants. Right. And what are some of your?
Absolutely.
Yeah.
I couldn't agree more. And, I think you have to meet a patient where they are. I'm personally plant-based, and I think it's great, but I also recognize that's not sustainable for most of my patients. And it's eating more plants and finding something that works for them. You could be healthy or unhealthy on any diet, but it's introducing more real foods, a lot of plants, and then moving more. And as you said, there's so many prescriptive diets and exercise programs. Keep it simple. I often just tell patients, take out your phone, look at your average daily step count. That's your goal, is beat that every day. And each day you try to just increase the amount of activity. And this way, on an individual level, you're moving more. The more active you are, the better it'll be.
Yeah, I mean, that's such a smart, I love that piece of advice. So look at your phone and just try to increase your steps each day. Real simple. We always want to keep things really simple. Any of your pet peeves that people are doing that you think are really putting them at increased risk for heart disease in the future?
As you alluded to with the supplement industry, supplements I think are good, and they can be good, but very often you see there's an openness to take 10 to 20 supplements, but when there's an indicated appropriate pharmacotherapy, there's no desire to take any pills or any medications, and it's really the same thing. We're both trying to treat different components, and one of the big differences is with pharmacotherapy, there's these rigorous randomized controlled trials evaluating it. So ideal if you could avoid medications, that's always the ideal, but there's a real need in certain scenarios to have appropriate medical therapy.
Yeah, I think that's a great point. I mean, the problem with the supplements right now, and we're not saying supplements aren't good or bad, I think it's very individualized, but I think you have to really, one question I always ask my patients when they're taking supplements is, why do you take this supplement? And I have to tell you, I think maybe once or twice in 20 years, the person actually gave me a legitimate answer. So, when somebody who is watching this show is taking a supplement, okay, fine, but if you're taking a supplement, please make sure you're able to answer the question, why am I taking this supplement? Right. And if you're not sure, then at least have a discussion with your physician.
You're right, and patient education is so important. Same thing with even the meds they're on. It's important if you empower a patient to understand why they're taking a medication, their compliance will improve, and also this way they're a partner in their health. I think it makes a big difference.
That's perfect. That's a great way to end this segment. So partner with your healthcare professional, be part of the team, and make sure you're making the right decisions. All right, Dr. Shlofmitz, thanks so much for coming in again, and we'll have to have you back.
Always a pleasure. Thanks so much.
Coming up, what's the future of preventive cardiology? You'll find out next on Stronger Together with Dr. Dave.
My boyfriend drinks too much. I found help and support at Al-Anon Family Groups. Is someone's drinking troubling you? You might be surprised at what you can learn in an Al-Anon family group from people just like you. Call 1-888-4-AL-ANON or go to alanon.org.
Welcome back to Catholic Health, Stronger Together with Dr. Dave. Today we've been talking about preventative cardiology with Dr. Thomas Pappas and Dr. Evan Shlofmitz. Now we're going to bring them both together to discuss the future of this very exciting field. Dr. Pappas and Dr. Shlofmitz, thanks for coming back. We want to go further with our discussion, and we now want to talk to the viewers about where is preventative cardiology going in the near future. There's a lot of exciting stuff, and things are changing really quickly. So why don't, Tom, why don't you start us off? Yeah. What is some of the biggest things that are changing in your own practice at St. Francis Hospital that is really not happening at too many other places right now?
I think originally we've got a CT scanner to look at early plaque buildup in the coronaries. So at that point, I'd be very aggressive in getting the LDL down, blood pressure controlled diabetes, hemoglobin A1C below 6. I think we should be very aggressive at preventing further progression of coronary disease. In the future, I think we should follow CT imaging over time. And I think it wouldn't be a bad idea to really do what we have at St. Francis Hospital to follow CT imaging over time. So I think that, to me, in the future, there's also something called Lp(a), which is part of the lipid profile. And I think they're coming out with a new medication now that maybe attack the Lp(a), which is a very sticky LDL particle. So I think that's something that we should probably look forward to in the future. But I think that's probably not, I think this is something that we need to really focus on as people, get older and whatnot. Early pickup of plaque in the coronaries from CT imaging, I get all over that. Down the road, we can follow them every couple of years and see if things have progressed over time.
So for you in your practice, the foundation seems to be moving towards patient comes in, image their arteries, and then figure out where their risk is.
Right.
Okay.
Exactly.
Evan?
I absolutely agree. And if you think about it, there's been a paradigm shift. It used to be our detection of coronary disease was an end-stage diagnosis. Patients would have a stress test or symptoms, and it's only abnormal once a patient has advanced disease, 70% or more. It's blocking flow. Where now we're detecting not when a patient needs a stent or bypass. With coronary CT, you can detect when a patient has 20% stenosis. And at this point, when it's not clinically significant, you can make changes. You can get dietary and lifestyle modifications, get them on the right pharmacotherapy. And instead of using these population-based risk scores to figure out, does someone need aspirin or a statin, you're actually taking a picture of someone's coronary arteries and telling them, does that individual need pharmacotherapy? And patients who don't need it, you get them off the medications. Patients who need it, it's a very powerful tool. When you show a patient what their artery looks like and they see that plaque, that's a motivator for lifestyle modifications, compliance with meds, and the tools and technologies have advanced so much just in the past year. We were fortunate not only to have one of the highest resolution CAT scanners, we're the first in the US to have a dedicated coronary CAT scanner with this new high resolution technology called photon counting, but there's also a secondary plaque analysis that uses artificial intelligence, and it allows us to see the exact volume of plaque inside an artery. And as Tom was mentioning, with serial CAT scans, we can follow and make sure that we're achieving our goals. And we can see not only are we preventing progression of disease, but what's been really exciting is watching in certain scenarios where if you're very aggressive in modifying a patient's risk factors, you can actually see regression in the plaque, where we see a plaque goes from 50% and a couple of years later, it's actually smaller. And that's really where the pharmacotherapy comes in, the powerful potent agents like PCSK9 inhibitors to shrink and stabilize that plaque.
Okay, so you just said a lot of stuff. So let's unpack some of that for the audience, because there's a lot of good stuff in what you just said. Right. The first thing is and I think we all agree here, and I think most cardiologists who are really pushing the envelope in their field would say, you really don't know somebody's risk unless you image their arteries. We have been all practicing long enough to know that patients will come in and they look fantastic on the outside, and then we image them and they are loaded with blockages and plaque, and then there are people who don't look so good and they have nothing going on. So that's number one. Number two, and I think this is one of the most fascinating parts of this, and I think people who are watching this show should take notes. If you don't have plaque building up in the arteries, you can probably hold off on a cholesterol-lowering medicine. And that's really important to know, because we put a lot of people on cholesterol medicines, and there are actually some people who maybe the risk of the medicine may outweigh the benefit. Now, that may change over time, but we can use imaging to help make that decision. It's a very informed decision as to whether somebody should lower their cholesterol and how much based on the imaging. Would you guys agree with that?
Yeah.
Yep, and even with antiplatelet therapy too, aspirin's not a risk-free drug, but same as not just the patient who doesn't need the statin, they may not need that. Just because you're 65 doesn't mean you need aspirin, and you're targeting it to patients who need it. That's individualized patient care.
Yeah, I mean, again, that's exactly right. So whether you need aspirin or not can be dictated by the results of your CAT scan, whether it be a calcium score or coronary CTA. Right. So, I mean, and it's so amazing to me that cardiology finally has just embraced this when we've been doing colonoscopies and mammograms. I mean, would you ever wait for somebody to have a mass on their breast to say, oh, we should do a mammogram? Why are you waiting for an event? Why are you waiting for heart attacks and chest pain? We are finally catching up as a field to the people who have been preventing this stuff, oncology, for many, many years, right?
It's so important. Heart disease remains the #1 killer of Americans, yet, as you mentioned, the screening, we screen for everything else. We wait for heart disease until they're symptomatic, and it's a backwards way, and luckily so much is changing, and it's, I think, what motivated Tom to create this preventative cardiology department, which is really going to help evolve our lifetime management of coronary disease and push that down the road. So I think it's so impactful.
Yeah, and again, if anybody's watching this show, they need to call St. Francis. We have cardiologists throughout Long Island. This table alone covers the entire island. You're out east, you're in Nassau, I'm in Suffolk, so we've got the whole island.
Got everyone covered.
Yes. All right, so that's great. So CAT scan imaging, have the discussion if you're watching this show. Let's talk about something else. Do we need wearable devices? Should I have my Apple Watch on my, all right, so this is a cardiologist who has a Garmin watch. Okay. Right. So what's your take? You have a Garmin watch. What's your take on, let's say, heart rate or heart rhythm monitoring?
My heart rate is usually in the 50s, because I do a lot of running, I do a lot of things, I do a lot of exercise, heart rate's in the 50s, and I think that if someone has a heart rate on their watch which is in the 90s, I think get on top of that. It's something that's very important, or if the oxygen level is low, then I think we have to get on top of that. So I think having these watches, I think, is phenomenal.
I think, one of the best things I've noticed with my patients is the reassurance. And, I always tell them, for those with an Apple Watch, it's pretty easy to get a recording, and everyone gets palpitations now and then. Right. And there's nothing better than you're having an episode of palpitations, and you can get that quick recording and see, does it say normal and your heart rate's 70 and sinus rhythm, or is it 150 and AFib? And it really helps them figure out, is this something I need to take a deep breath, calm down, or this is something that we should escalate and maybe go to the emergency room for. So it's that immediate feedback. And also now you have an educated person on the other end. When they're calling you about the palpitations, they're giving you feedback. They're telling me, oh, I'm in sinus rhythm right now, but 90. Right. And to have that, you can help guide them for what the best next steps are. So I think more information is always helpful, and it really helps, again, having the patient be a partner in their own care.
Okay, so we have two proponents. I'm in the middle. I see the validity of having these devices, especially the rhythm monitoring. My only concern is the anxiety component of you. I feel sometimes the people who should be wearing it don't wear it, and the people who shouldn't be wearing it do wear it.
It's like medications
the people who are in really good shape, like Tom, are wearing it, but my 75-year-old who I'm wondering if they're going to go into AFib is not wearing it. So yeah, I think the future of heart rate monitoring is definitely here to stay in the right person. How about AI? Are we going to be taken over by AI? We won't need doctors anymore because we have Dr. ChatGPT. What do you guys think about that?
I think AI, 100%. In fact, I always go into AI and ask, what is this, and it corresponds and gives me all this information. I think it's something that's phenomenal. But to do stents or to do coronary angiography, I don't think AI is going to do that.
Yeah.
I don't think they will.
The only thing I would say to that, though, is, and I agree with you, but the one thing I always tell my patients is when they come to see me, they can read as well as I can read. Right. It's the ability to integrate what you're reading into practice, and how does it change management? So yes, AI is great, and I use it also from time to time, but I think what the doctor's value is going to be is experience. Yes, AI is saying we typically use this medicine for this condition, but in our experience, is it as good as AI is saying, or are there better options? What do you think, Evan?
Yeah, AI is here to stay, and it's only going to get better and more a part of our society. But I agree, our role is still the guide. I think it helps a more informed patient. They come in with more information, but here you're still guiding them on how to decipher that and to really help individualize that. But I think AI, both from the patient education standpoint, that's really helpful, but also from everything we do, I think this is a part of medicine, and it will be integrated more and more. And even in the cath lab, where we still have a role, AI is helping us with more efficient and more accurate decision making, and it's a great teaching tool. Intravascular imaging now, most of the companies all use AI in real-time analysis of exactly what the plaque type we're looking at, what the size of the vessels, and it just helps us get more accurate diagnosis.
Yeah, I think it's going to help us be better doctors, definitely. Yeah. And I think we will make less mistakes in medicine because of AI. Yes. It's that extra layer of somebody watching over us and saying, that mass that you've been watching, that lung for the last 5 years hasn't changed. You don't have to keep checking it and subjecting the person to radiation. And then, so where do you think in the next 5 to 10 years, what do you foresee as the biggest game changers that we talked about so far? Is there one thing in particular you're most excited about?
I think, with respect to preventing plaque buildup, I think finding a medication that attacks the Lp(a), which is a very sticky LDL particle. I think if that medication comes out on the market, it may be very helpful to really attack the cholesterol level. So I think that's probably something where they're coming out with it in this year or something.
They keep saying, but in 2026, maybe
Yeah,
2027.
Right. So that may be something that maybe we may use going forward to prevent further issues.
And if the viewers don't know what LP or lipoprotein is, they should talk to their doctors about that. This is really important that 1 in 5 people, or 20% of the world's population, has elevated LP(a).
Right.
We never tested for it before because we didn't have a treatment, so we kind of look the other way. But we really should not be looking the other way because it is a predictor of risk either way, whether you can treat it or not.
It really is.
Yep.
Yeah.
And with available technology even now, that's coming very soon down the pipeline. But right now we have PCSK9 inhibitors, so the drugs, the brands are Repatha and Praluent, that really powerful drugs that you can customize who needs it based on coronary CT. But a major development just recently, they published a study, Vesalius, which shows that this isn't just for secondary prevention. It used to be for patients who've had a heart attack or had a stroke, preventing them from having the second event. But now we don't have to wait for them to have an event before we can treat and modify their risk. And what Vesalius showed was that for primary prevention of an event, patients who have atherosclerosis, who have diabetes, that we could get them on optimized medical therapy now and help prevent the progression, so hopefully prevent and delay them having that first event. So that was a really big advance, I think, in the field of cardiology and coronary disease management, and certainly preventative cardiology.
Yeah, I'm going to say something that's a little controversial, but I am going on the record saying nobody should ever have a heart attack. I think every heart attack is mostly preventable. Yep. I mean, if you screen people early enough, there's no reason we should not be the #1 killer in the world anymore, because we have the technology, the CAT scans to pick up disease early enough, and we have plenty of therapies to lower the different risk factors. So I think in the future, what makes me most excited about cardiology is this is just going to be maybe a disease of aging, but nobody will ever have heart attacks or bypass surgery or these extreme procedures. I think it's just going to be a part of aging. And yes, you may need a medicine here and there, or maybe a vaccine in your 20s, right, against atherosclerosis. But I'm excited to know that this will hopefully be something we read about in the textbooks 100 years from now and think how crazy it was. We were doing all these procedures on something that was initially preventable.
Right. Now, if we could convert it from an unstable, high-risk disease process like a heart attack to just a stable disease, it changes the way that we can manage it. And that's certainly the goal.
Right, and that's a great way to end this segment. So thank you both for coming on. I'd love to have you guys back on in the future, because things are changing month to month, year to year, so we have to keep on top of these things. Yep. Okay, great. Thank you to our guests today for sharing more about Catholic Health's preventive cardiology program. If you would like to know more about Catholic Health or to make a gift in support of one of the amazing programs you heard about today, please visit CatholicHealthLI.org or call 1-855-CHS-4500. Thank you for watching today. I am Dr. Dave Degatti, and I'll see you next time on Catholic Health, Stronger Together with Dr. Dave.